development and some associated disorders. First, we'll talk about, I'm in presenter mode. Let me see if I can switch that.
Yeah.
There we go. How's that? So first we'll go over, spinal development and some of the immediately related disorders, and then we'll sort of circle back and talk about how some of the genes that are implicated in those early stages later go on to play roles in disorders that we see at different stages of life. And we'll look over some cases and we'll ask some questions. This is highly tailored, hopefully as a good resource for board review, since a lot of the residents will be taking boards in March. So just as a overview, that development of the embryo, starts with initially ovulation, and it's in the first days 1 through 8. It's in the morula and blastocyst stage before it implants. It then forms a gastrula, which differentiates into the 3 germ cell layers. And our CNS is formed through neurulation, initially primarily neurulation, and then secondary neurulation, which we'll talk about some of the associated disorders. Basically, these first slides show that there are a number of genes associated with this initial development, which we'll circle back, and we'll talk about some of the associated disorders with related to those genes. Defects with gastrulation, that early stage where we get differentiation into the 3 germ layers, include split cord malformations, neuroenteric dermoid and epidermoid cysts, anterior and posterior spina bifida, intestinal malrotation, duplication of fistula, anterior meningoceles, and other complex dystrophic malformations. For some of those who are in their board studying, maybe Emily, do you know what kind of split cord malformations these are on the right and left?
So on the right here, looks maybe like a type 1. I'm sorry, on the left, type 1. Diastomatomyelin. And then I think on one on the right would be a type 2, reticulomyelia.
Great. No, that's right. The main difference here is the one on the left has 2 separate dural sacs. The one on the right has 1 dural sac, but the cord has split in 1 segment. And so, as you said, there's 2 types of split cord malformations. Type 1 was formerly called diastomatomyelia, and it specifically has 2 dural sacs. Sometimes it has a bony ledge in between them. And split cord malformation type 2, formerly called diplomyelia, usually has 1 dural sac with a portion of the cord that is split. True dimyelia of note or complete duplication of a normal spinal cord has not been described. And clinically, we often see tuft of hair, and these can indicate a split cord malformation. Here in picture B, they point out a sacral dimple that is associated also with a fatty filum terminale. So beginning post-ovulation day 17, the median hinge point forms to begin folding the neural plate and to begin our process of primarily neurulation and the formation of the CNS. There are additional bending points, and this begins sort of the elongation and differentiation of the CNS. The anterior neuropore closes, around post-ovulation day 24. That varies slightly between resources, post-ovulation day 25 and so forth. This manifests as a thickening in the dorsal portion of the embryonic in the dorsal portion of the embryonic lamina terminalis. This will essentially form our cranial portion of our CNS, and the anterior neuropore will then form the three primary buds that will form the brain, cerebellum, brainstem. The caudal neuropore closes around post-ovulation day 26, and it corresponds to more distal portion of the CNS at the S2 level. And this is primary neurulation. Defects of the dorsal ectoderm can involve any level in the neuroaxis, and they form dermoid cyst, epidermoid cyst, or dermal sinuses. Defects of the dorsal mesoderm turn into either interspinal lipomas or lipomyelomeningocele. This leads to either an open spinal dystrophism or a closed spinal dystrophism. Open spinal dystrophism don't have a skin lining over them, so they form myelomeningocele. Chi, what is a myelomeningocele associated with higher up? Being shown in that picture as well.
Like Chiari malformation.
Chiari-2 specifically. Right. And then closed spinal dystrophism have a skin overlying them. A split cord malformation is usually closed spinal dystrophism, but it can have an open component. So it's not always a closed spinal dystrophism. Secondary neurulation begins later, post-ovulation day 25 to 27, and it forms the embryonic tail, so below S2. And rather than a folding, it's more of a cavitation. And then defects involving the caudal cell mass or primitive streak lead to caudal agenesis, which range from partial to complete absence of the coccyx and sacrum. All right, so I just want to circle back, and there are a lot of genes implicated in all the formation of the primary germ cells, layers, and then the various portions of the CNS. Here you see Wnt1 as one of the genes, which is heavily involved in the pre-gastrulation stage. And here in gastrulation, I want to point out hedgehog, which is involved in ventralization. Those two genes we see in a condition which is divided into 4 groups. And 2 of the groups correlate to those genes, Wnt and sonic hedgehog. And I'm wondering, maybe, Halima, do you know what we're talking about here?
Medulloblastoma.
Yep, that's right. Good. So medulloblastoma is divided into these 4 groups, and they're thought to each derive from distinct cells of origin. Do you know which one has the better prognosis, which one has the worst prognosis?
The WNT one has the better prognosis.
And which one has the worst prognosis?
The G3 and the G4.
Yep, G3 is commonly thought to have the worst prognosis, as seen down here in this chart. So that is commonly asked. Staging is according to Chang's operative staging system based on whether you have any metastases, presence in the CNS, intracranial leptomeningeal spread, spinal leptomeningeal spread, or metastases outside of the CNS. There was a gene involved in the pregastrulation stage named brachyury, which is part of that same pathway as the Wnt gene. And brachyury, we see commonly discussed with another condition. So a patient shown in the scans below is sent to your spinal clinic, and this tumor was biopsied and has strong brachyury overexpression. What are you treating here, Alex?
It's maybe chordoma.
That's right. Chordomas tend to occur in the sacrum. They also tend to occur in the clivus. Here is on the top some images of an intracranial clival chordoma, and on the bottom sacral chordoma, showing the various sequences and its appearance. Over in the CT, you can see how there are some calcified portions within it, and that's thought to be normal bone within it rather than calcified bits and pieces. So chordomas is a slow-growing radius-resistant tumor, but they're locally aggressive and invasive, highly recurrent, even seeding along the operative tract. They're rare cancers. They tend to occur, their prevalence is sort of evenly split between the skull base, which tends to be the clivus, the mobile spine, and the sacrum. It makes up notably over 50% of the primary tumors of the sacrum. Peak incidence is mostly later in age, and they rarely occur in kids, but when they do, they can be encountered in children with tuberous sclerosis. Median survival is 6.29 years. So even though it is a benign tumor, is so locally aggressive that large, wide excision is the primary treatment when possible. And there are, limited chemo and radiation options for these tumors. They were first characterized microscopically by Virchow, and he described these the pathology of it as these bubble-like vacuoles that he referred to as fistulariferous, so as like a pathognomonic pathology term for them. But Ribber first introduced the term chordoma in the 1890s. Brandon, why do you think perhaps he introduced the term chordoma? And it has to do with its cell of origin.
Because it comes from the notochord.
Yep, that's right. It's thought to derive from notochord remnants. 3 subtypes are recognized. Conventional chordoma is the most common. There's also chondroid chordoma that has the best prognosis, and the more poorly and dedifferentiated chordomas are least common, but they have the worst prognosis. They're also associated with this SMARCB1 gene homozygous deletion. Brachyury has also been implicated in a number of other cancers, just so you know, and it's usually its overexpression correlates with worse prognosis. Going back to gastrulation, I also just want to point out the Hox gene here, which is implicated in left and right symmetry. And interestingly, lumbosacral transitional anatomy there's studies suggest that it has a genetic component involving the Hox genes, and mutations in these genes may play a role in the formation of the lumbosacral transitional vertebrae. Lumbosacral transitional vertebrae are seen in about a quarter of people. Sacralization of L5 is much more common, about 17% of the population, while lumbarization of S1 is only about 2% of the population. And the prevalence is higher in men compared to women. And sacralization, the more common of the two, is more common in males, while accessory L5-S1 articulations and lumbarization of S1 are more common in women. And low back pain in the presence of these lumbosacral transitional vertebrae was originally noted by Mario Bertolotti and termed Bertolotti syndrome. There is a Castelvi classification, which classifies them primarily into three types, where types A are unilateral, types B are bilateral. Type 1A is just a enlargement of the transverse process of at least 19 millimeters. Type 2 is an actual pseudoarthrosis or pseudoarticulation. Type 3 is a complete fusion of the transverse process to the sacrum. And type 4 is a combination of type 2 on one side and type 3 on the other side. Going back to this gastrulation stage, we also see BMP, which is involved in dorsalization of our gastrula. That has been implicated in this condition. This patient is referred to your clinic because of myelopathy. And what strikes you about the CT scan, Noah?
Looks like the posterior ligament is severely ossified. So this is consistent with OPLL.
Yep, correct. Ossification of the posterior longitudinal ligament is attributed to proliferation differentiation of fibroblast-like chondrocytes and osteoblasts, which may be caused by overexpression of bone morphogenic proteins in the ossified ligament. And so rather than well-organized fibers, you get this cartilaginous tissue with centers of hyalinoid degeneration and ossification. OPLL also involves other genes, such as COL6A1, BMP transforming growth factor beta, others. And it has been linked to other disorders of aberrant ossification and bone homeostasis that we'll talk about briefly. It can be divided into 4 different types based on whether it's continuous or segmental, mixed or localized, and it can cause various degrees of symptoms. On the other hand, you referred this patient with a related condition to your clinic. What strikes you about his imaging, Trevor?
You can see at C, well, he's got tons of dish anteriorly. He's got a fracture at C3-4 through that ossified anterior longitudinal ligament.
Yeah, that's right. So rather than PLL being ossified, here the ALL is severely ossified, and as you said, this is known as diffuse idiopathic skeletal hyperostosis or Forestier disease, which is ossification of that ALL, and it involves the formation of these enthesopathies. There's also of note, there's no involvement of the sacroiliac synovial joints in these patients. And yeah, you mentioned a good finding at 3-4, which is an interruption of that. Sorry, I seem to be. Let me go to this slide here. And we'll talk about this in the context of ankylosing spondylitis also, but since you mentioned it, there's almost like this Anderson formation which we'll come back to in a moment. Let's say a patient is directed to your clinic with this similar hyperostosis and ossification of the cervical spine. She has this wide webbed neck. What would you be, and she also has some other related comorbidities. She has deafness, perhaps a cleft palate. What might you be concerned about? Chi.
I think given the fusions in the cervical spines and some of the other associated symptoms look like the Klippel-Feil syndrome.
Very good. This is a Klippel-Feil, which most commonly presents as a sporadic mutation, but can have autosomal dominant inheritance as well as autosomal recessive inheritance, depending on which genes are implicated. It can be caused by mutations in GDF6 or GDF3 genes, which is inherited in an autosomal dominant pattern. And these GDFs are members of the bone morphogenic protein family. When it's caused by mutations in the MEOX1 gene, it's inherited in an autosomal recessive pattern. Several other genes are linked to Klippel-Feil, including Hox genes, SGM1 and PAX1. There are several classification systems summarized in the table. Very good. So the next patient you see in your clinic, it has a particular form of hyperostosis with this morphology. And they have a couple other findings. Emily, can you run us through these scans?
Sure. So that lower left image, definitely seeing just this like overall straightening of the, I think it's probably thoracic spine, with just not a lot of, yeah, like I said, it's just straight between the vertebral bodies and the discs. On the left upper, I see a cervical and thoracic sagittal CT. Notable for it's a straightening of the lordosis, and looks like it's infusion on C2 and C3. Then the right lower, it's a pelvic X-ray. I think
I agree with everything you're saying. Do you know what condition this patient might have?
yeah, I think it's very likely ankylosing spondylitis. I think the biggest giveaway is the bamboo spine on the that left lower panel.
Perfect. Yeah, that's the textbook term to sort of describe this appearance of the spine, where all the various segments have fused together, creating this bamboo appearance. On the upper right, Brandon, do you know what this image is showing?
Looks like a epidural lipomatosis.
Okay, well, I didn't show you some of the other sequences that might help you differentiate that. But this is actually showing dural ectasia. So it's like an enlargement of the dural sac. And down on the bottom right, this is showing you a X-ray of the sacrum and pelvis, at least the right SI joint. And you basically don't see an SI joint, it's fused. And this is central to ankylosing spondylitis. It's fairly common, affects 1 in 200 individuals. And it often occurs with other peripheral arthritis. It can also occur with uniocular anterior uveitis that can be treated with corticosteroid drops. These patients also have a risk of developing apical pulmonary fibrosis as well as aortic valve incompetence. They usually develop late in the course and are often asymptomatic. Also, poor osteopenia and osteoporosis commonly occurs with these patients. That increases their risk of vertebral fracture. Ankylosing spondylitis has a strong association to HLA-B27. And as mentioned, it often involves the sacroiliac joint and causes the sacroiliitis and eventual fusion of the joint. So a pelvic X-ray or MRI is often used. As you can see here on the right, we have some of the diagnostic criteria, and the sacroiliitis is a strong supporter of ankylosing spondylitis. Patients create these syndesmophytes, which are different than osteophytes. Rather than, this disc degeneration and sclerosing of the end plates, you get what are called these Romanus lesions. And in early disease, you can see that sometimes in X-ray as this sort of lightening of the tips of the end plates, which then over time sort of fuse together with the adjacent vertebral segment. And this creates one big fusion body in the spine. And as mentioned, these patients are at high risk for fracture. And they often develop these fractures seen here, which are termed carrot stick fractures. Maybe you can just imagine a carrot snapping. And sometimes these stress fractures heal over time to form these Anderson lesions. So we talked about dural ectasia, and dural ectasia is associated with a number of syndromes and disorders, from Marfan or Ehlers-Danlos connective tissue diseases to NF1, ankylosing spondylitis, osteogenesis imperfecta, trauma, post-surgery. So let's say that you get a patient in your clinic who is referred to you for scoliosis. You can see on the bottom left has a really severe scoliosis. It's surely notable externally. And even though this is not a picture of this same patient, your patient has these similar spots as well, seen on the upper picture. And you notice a particular appearance in their eyes, and they also have these associated findings. Halima, what are some of these findings?
So the skin pigmentation in the middle panel looks like cafe au lait spots, and then the eye findings look like pigmentation in the iris. So the piece like these nodules, and then seems like on the CAT scan, patient has an optic tumor of the optic nerve, could be an optic glioma, and then on the bottom panel also has dural ectasias, as you showed in the previous slides. So overall, the patient should have NF1.
Yeah, very good. And I'll try to go quickly because I think we're out of time, but that's exactly right. NF1, or von Recklinghausen's disease, which is autosomal dominant, with implicates the NF1 gene in chromosome 17 and the neurofibromin gene, tumor suppressor gene. And these are cafe au lait spots seen here. These are skin cutaneous neurofibromas. These are Lisch nodules. You pointed out the optic glioma. And these patients often, or they can have sphenoid dysplasia as well, which can also be seen in this CT scan. As mentioned here, these are just pictures of neurofibromas. We recently had a patient on the spine team who had these lesions. And the various findings here, there's a meningocele as well. And this is just scalloping of the vertebral body seen on X-ray, both posteriorly and then anteriorly here. Now you are referred this patient with a which has two different patients that you see back to back, and one at the top with these large lesions next to the spine and intracranially, and then this patient with one spinal lesion and these two sort of pathognomonic lesions intracranially. Chi, what do you have to suspect in these patients?
I think looking at a scan at the bottom right, looks like potentially bilateral vestibular schwannoma. That would make me think about NF2.
Perfect. So NF2, also autosomal dominant with the NF2 gene on chromosome 22. It implicates the Merlin tumor suppressor gene, and bilateral vestibular schwannomas are pathognomonic for it. So that gives you your diagnosis, quick review of the pathology of the schwannoma. You know, you see the school of fish, and then the Antony B and Antony A portions of it, where Antony B is sort of this loose on the right-hand image, the left part of the image, and the Antony A are these tightly packed cells, and Verroque bodies seen here. And then meningiomas, you know, there's many different types of meningiomas with various pathological findings, but they commonly have psammoma bodies and whorls. And just quickly to go over tuberous sclerosis or Bernardville disease, it also autosomal dominant, either the TSC1 gene or the TSC2 gene, implicates the mTOR pathway. Emily, do you know what mTOR stands for?
It's a signaling pathway. The M is mechanistic, and then target of rapamycin.
That's right. So it's the medicine that targets it is in the name of the gene. So rapamycin or sirolimus, or it's or everolimus are used as medical treatment for tuberous sclerosis. Can have these various findings. Here you can see cortical tubers, SAGA, as well as cutaneous angiofibromas. You can also have subungual angiofibromas seen in the left lower image, shagreen patches, which is left upper image, ash leaf spots, or adenoma sebaceum, which are these cutaneous angiofibromas. Last question. Emily, looking at these set of images, do you know what this patient might have and what you might expect this spinal lesion to be?
So in particular, looking at the appearance, it's pretty heterogeneously enhancing in the cord, and then also these cerebellar lesions, multiple lesions. Looks like in the kidney as well. All this together, I think there are likely these multiple hemangioblastomas that you would expect to see in VHL.
Perfect. Yep. So you see this large heterogeneous cerebellar tumor, along with liver cysts or pancreatic cysts and liver cysts. And you see a spinal lesion, which based on this, putting all this together in its entirety, you can expect to likely be a hemangioblastoma as part of VHL, which is autosomal dominant and implicates chromosome 3. It can have cerebellar hemangioblastomas, which were historically termed Lindau's tumor. It can also involve retinal hemangioblastomas, which were historically termed von Hippel's tumor, as well as kidney pancreatic cyst, kidney cancer. So great job, everybody. That's all I have, and thank you very much. Hope that helps for the boards.
Nice job, Alejandro. This is a good board review of high yield topics. All right, so today we have one of our newish faculty members, Dr. Travis Caton, who is an assistant professor of neurosurgery and specifically specializes in neurointerventional surgery. He did his training